Good morning, everyone. First, I'm really sorry that we weren't able to be there in person. And just to let you know exactly how this will go, the first thing to remember is we can't actually see you all in the room. So if you're nodding or if you're giving a I agree, I promise that we'll feel the energy. So still feel free to do that as we go through our presentation. I'm actually going to be presenting today with my colleague, Fatima Clark, who is one of our associate directors here at Children Now. And I'm really excited to have worked on this project with her. And just as a little bit of background, we decided to even embark on this project, which we're calling Robust Data Systems Needed in Children's Behavioral Health, because we realized a few things. One, everyone is kind of aware of what was missing in the children's mental health data conversation, but I realized there wasn't a lot of clarity around what currently existed. For those of us who are deeply steeped in it, you might be very familiar with what's collected on the county level, for example, or what's collected with managed care plans, but we've never really seen anything all in one place. So that's what we set out to do. Whether or not we were successful is really up to you all as you judge our work. But I wanted to make sure that you had just a really good introduction before we started. So without further ado, I will welcome Fatima Clark, and I will be controlling the slides. So let me set that up for you.
Thanks, Lishaun, and hopefully everyone can hear me okay. And good morning. It's great to be with you all this morning. So I will just kick it off. Next slide. So folks might be very familiar with Children Now and who we are, but for those of you who aren't, next slide, Lishaun. Children Now is a statewide policy advocacy research organization that's dedicated to promoting children's health, education, and well-being. We really believe in pursuing a whole child approach in our advocacy work. So we do work across all these different issue areas as an organization and as colleagues at Children Now to sort of advance policies that promote optimal outcomes for kids in our state. We also at Children Now lead the Children's Movement of California. If your organization isn't a member, please become one. We're trying to get to 5,000 this year. But essentially the Children's Movement of California is a network of over 4,600 organizations across the state from all kinds of backgrounds, faith-based, child care providers, healthcare, child welfare agencies, education institutions. It's pretty much anyone and everyone in California who believes that kids should be prioritized. And so the Children's Movement works to that end. And so if you're not a member, please consider becoming one. So that's a little bit about Children Now. As Lishaun mentioned, a little bit on the purpose of this project or research undertaking is that we really wanted to identify what metrics are publicly reported on children's mental health and substance use from various state agencies and or entities that work with state agencies. So I'll talk a little bit more about that in a few minutes, and identify the data gaps and recommend ways that California can improve data collection efforts to really better understand how children and youth are faring in our state. Next slide. So we, throughout the course of a year, scanned a lot of state department websites. We looked at the Department of Healthcare Services, the Department of Social Services, the Child Welfare Indicators Project, which is a collaboration between UC Berkeley and CDSS and I'm sure other agencies. We looked at the California Department of Education, again, trying to scrub through what do we know about children and youth and their mental health or substance use, treatment, outcomes, access, just anything that might mention mental health. We wanted to make sure we could see that. So we looked at various state agencies. Next slide. And what we found is that there were 80 metrics. This is not an exhaustive list because we did limit the criteria to state agencies' publicly reported data. So there are measures that are collected by the state but are not publicly reported. We did also limit our criteria in terms of, in reviewing for this data that was available within the last 3 years. So of the 80 metrics that we found, there's countless more. In fact, this year, as an example, state maternal, infant, and health assessment data was just released. That's one measure that we really wanted to include in here. It's not included, but it's because the data was that was publicly available was outside of in the last 3 years. But across the domain, across the metrics that we found, as you can see, we categorize them into two sort of big buckets of domains, which is population indicators, which tell us something about the child population and their behavioral health, and then system performance indicators, which describe how the system itself is performing and functioning for kids. As you can see on the screen, there's a lot of information on system use and early identification, things like who's at risk for larger behavioral health issues, or how many kids are getting specialty mental health services. Consumer satisfaction, while collected, we could not find publicly available data. And as you can see, measures on outcomes, quality, and consumer satisfaction, that's where we have the least amount of publicly available data as it relates to children and youth mental health measures. Next slide. So at the bottom of all these slides, I hope you'll play around with this, or I hope you have already played around with the tools. You can really use our online tool, which lists the 80 metrics that we found, and you can search, sort, filter by domain, which is those categorizations that we identified for the 80 metrics. By focus area, is it substance use, suicide, mental health? By measure, so is it an timely health appointment? You can get a sense of all the information that's available. Measures vary depending on if they break information down by health coverage type. So we do include that when we have that information. The agency, the source, if race, ethnicity breakdowns are available, and as of last year, when it was last reported, and the frequency with which it was reported. So again, some items are missing. They just fell outside our 3-year mark, or they're not actually publicly reported, even though they are collected. And with that, I'll hand it over to Lishaun.
Great. Thank you so much, Fatima. So a lot of this is probably going to be things that you've already heard about the gaps in the data system and that data report. So I won't spend too much time on it because we definitely wanted to leave time at the end for questions. We know how hard it is to, engage virtually in this way. So we're hoping to make this as interactive as possible. So we found, obviously, that there were significant gaps in disaggregated demographic data. And that was everything from race and ethnicity, which I think gets talked about a lot publicly, to SOGI data, which is sexual orientation, gender identity data, but also age. And for children, this is really important because the expectations of what needs to happen, say between a 0 to 5-year-old and an 18 to 21-year-old or 18 to 25-year-old, our transition age youth, is very large. So we really thought that we needed to have a better understanding of what was going on by age group for children, so that we're not lumping in all of the outcomes or all of the data just in one under 18 or under 21 age group. So a lot of the conversations around race and ethnicity and SOGI, you folks are already familiar with, but I will say that as the state embarks on a lot of equity conversations, it's going to be almost impossible, I would say, to reach any of those goals if they don't have better demographic data that they're collecting. And we'll talk a little bit towards the end about some opportunities the state has to actually collect better data. So we do see that there's a light at the end of the tunnel. There's also a lack of data on non-clinical settings. And what we mean by that are settings in the home, in the community, at school. And we know how hard it is sometimes to collect data, particularly data that might be in the home and community. But we saw this as really important because children exist outside of just the clinical setting. And depending on how old they are, they actually might not be getting as many doctor's appointments or going into the doctor's office as often as they might have been when they were much younger. So really having an understanding. And then the other thing is we need to understand what's happening in home and at the community because it has an impact on how they learn, for example, how their social environment is faring, their relationships and attachments are faring. So really understanding what's happening outside of clinical settings is crucial. Most of the data that we saw were based in clinical settings. And then of course, there's no consistent data across delivery systems. Most of the data that we collected or that we saw was from the Medi-Cal system. And I know Karen mentioned earlier about, how much better some of the services are delivered on the county level. We completely agree. A big part of that is because we know what's happening on the county level. And we have a better understanding of what's happening on the county level because we track it so closely. We don't do such a good job with private coverage. Right now, there are a few things happening, and it does feel like every day there is a new initiative going on to get better data or to get better outcomes. So the most obvious is the Children and Youth Behavioral Health Initiative, right? And so the thing there is that initiative is actually charged to, quote, develop the interventions, goals and metrics used to determine a Medi-Cal managed care plan's eligibility to receive the incentive payments. And this would be under the Medi-Cal managed care program that is supporting health plans to connect with schools. So there is a conversation that needs to happen around data in schools and bettering that data. So they do have that charge in statute. Next would be the Cradle to Career data system, which is something that I'm surprised isn't talked about a little bit more. This was passed in 2019 to 2020 during the state budget agreement. It's $10 million one-time funding, and their plan is to provide a longitudinal data system. And so they're not necessarily looking to produce new data, but they are looking to connect data from early ed providers, K through 12, higher education institutions, employers, workforce entities, and HHS, Health and Human Services. So how can we use this opportunity for cross-sector data, which is what we really need to have a better understanding of how kids are doing with the Cradle to Career data system? And then finally, CalAIM, one of the largest initiatives right now with Medi-Cal. But, at a high level, we know that the Population Health Management Service is expected to really include opportunities to identify and provide case management. And in order to do that, they're going to have a robust data system available. So we're really excited to see these opportunities that the state has. One thing that I've always flagged for folks is unless these initiatives are working somehow in concert with one another, even if the very bare minimum is knowing what the other group is doing, you might actually just have three separate and distinct data systems that might all independently be working well, but could in theory work a lot better if they had similar goals or if they were talking to each other. So those are the things that we see as having a clear opportunity in the future for a better data system for children and youth. So the other thing that I want to also flag is we really have underutilized consumer experiences and satisfaction. And I know a lot of folks feel as if that's not a good way to really understand what's happening, but we really are pushing for more consumer experiences and satisfaction data. One, particularly if we're thinking about how youth are experiencing the system, we think that their voices are important to incorporate. There's really no reason why we shouldn't be asking young people at a bare minimum, how they're doing, how they found navigating a system, whether it was at school or not, and what else we could be doing better in order to meet their needs. So it was very surprising to us that we saw absolutely no consumer experiences. And every now and then, if you do come across a data source that, focused on consumer experiences, they were a one-time project. They weren't something that the state was investing in regularly to report out on for us to see how folks were doing and how they were feeling about the system and the care that they were receiving. And then, of course, a focus on quality and outcomes. We strongly believe that there is just very little focus, particularly on outcomes. We are not clear on what outcomes we want for children. So we have not stated, for example, that we want to decrease the suicide rate for the LGBTQ community in X zip code. We haven't gotten that granular. It's hard for us to get that granular, but that's what we really need to be thinking about if we're thinking through how to make sure that we see the things that we want to see when it comes to children and youth. So the outcome data, I think we only saw about 4 or 6. And one thing that Fatima didn't mention is that some of the data metrics were crossover metrics, meaning you could put them in one bucket and another. So it could be access and quality, for example. So that's why those numbers didn't quite match up to 80 if you were doing the math in your head and wondering how we had such a large number with only 80 metrics. So we're really thinking through what it means when we talk about quality and outcomes, and how can we use consumer experience and satisfaction to determine those things. Here is a short list, something that, we aren't saying this is exactly what needs to happen, but what we are saying is these are some things that should probably be collected, that we would like to see collected. It's not an exhaustive list. But you'll see here that we are specific about the 0 to 5 population, for example, percent of kids 0 to 5 receiving support for an identified developmental or behavioral health challenge. That's something we would love to know. And I think many of us in the room at Breaking Barriers sees that this is really important to know and to work on. And you've also have some consumer experience suggestions here on percent of youth satisfied with provider, or percent of youth satisfied with the frequency and type of services that they received. I think that would also be good for us to know. We also want to loop in parents, percent of parents reporting concerns about their child's development, right? We want to hear parent voice. We want to know what's going on with parent. And then finally, you have some cross-sector metrics that are really important to have a better understanding of what might be happening with a child's behavioral health, like the number of percent of young kids suspended and or expelled from childcare programs due to behavioral issues, right? Or the number of percent of missed school days due to mental health related issues. We know how important it is for emotional well-being and good mental health, and how one shows up to childcare or how one shows up to school, that it really seems like a missed opportunity from our standpoint if we're not tracking how those two are in relation to each other. This is our contact information. I think I'll stop now and kick it back to those in the room to see if there are any questions.
Lishaun, it looks like you dazzled them.
No, the good news is you can lie to me and I wouldn't know.
Well, I do lots of things, I don't lie. But there is one question. All right, there are 2 questions. Please, yours first.
Oh, me first. Okay, sorry. No, I really like what you said about the outcomes of the data that you're collecting. I work for an SDRTP program, and we collect data twice a month from youth that we're currently serving. And it's a pretty extensive list of questions to ask. But the one thing that I've noticed is, as an advocate, I'm supposed to do this, twice a year, is what are they doing with all that data that they're collecting? Because I don't see it, but I don't see the outcomes of it.
Okay.
I see the collecting of it and crunching the numbers, but I don't see the outcomes of the data that they're collecting. So I really appreciated that you pointed that out.
Okay. Lishaun, did you hear all of that, or otherwise I'll translate?
I think I did. I think I heard
Okay.
that, you know, a lot of data is collected, but she doesn't always see the
You got it.
outcomes related to that. And, you know, that's something that we found as well on our journey of even looking at what's available. There are so many metrics. One of the reasons why we scoped it to only 3 years and only scoped it to what's publicly available was because we would have been doing this project for 5 years had we not put some parameters around it. And I think that's a great question. One thing that I know folks get uncomfortable with, but I think we should talk about it, is what metrics are we collecting that we don't need to collect? What metrics can we get rid of and instead introduce new metrics so that folks who are collecting data aren't overwhelmed from the pure process of data collection?
That answers your question?
Yes.
Good. Okay, Tony?
My question has to do with the comments that you had made earlier about this lack of awareness or understanding, or maybe there's some transparency with the private insurers. And what is, if you're aware of any efforts that are being made to engage private insurers to ensure that we're gathering that type of information.
So I think this question is about private insurers and what efforts are being, okay. Yeah, so right now the Department of Healthcare, they are hosting a stakeholder work group called the DMHC Health Equity and Outcomes, I could be butchering the name, subcommittee, and it is a committee that they created by law. It was created after we did this report, so a lot of things have happened since early 2022. And they are looking at what metrics they should be requiring private plans to report out on. Children Now does sit on that stakeholder work group. We're hoping to get some strong metrics of reporting. We would like to see a combination of beefing up metrics that already exist that they might already be collecting on, but they're not collecting on consistently or reporting on consistently, as well as introducing new metrics. It's something that the DMHC is going to have to revisit in another 5 years after we get through this first stakeholder process. So I would keep an eye out on that. I think you can go to their website and sign up for the stakeholder meetings that are happening because they are open to the public.
There's a follow-up question.
I appreciate that. Thank you very much. I'm wondering if there's any conversation around aligning their systems of care requirements and expectations with the Medi-Cal delivery system. So for example, in trying to engage them to get data about what their systems are doing, is there any kind of an effort to say, can you tell us which of your youth would have qualified for specialty mental health services, something like that, to get a better understanding about the total population in the state of California?
So I think I missed some of it at the end, but I think the question is about whether or not there's alignment between what DMHC is doing and what Medi-Cal is doing.
No, with the private insurers.
With the private, because he wants to be able to so we have a snapshot of what's happening for all children, not just them in the two systems.
And so, like, for example, is there any kind of conversation about asking the private insurers to assess whether or not one of their youth that they're serving would have met criteria for specialty mental health services, something like that?
I see what you're saying. That's not quite I know that through CalAIM, they're trying to, get managed care plans a little bit more clear on how they are referred to specialty mental health services, but I haven't heard similar conversations on the private side.
Okay, thank you.
Yes, just speak loudly.
Yeah. How are you all handling the challenge of our different systems collecting demographic information in a different way? So, for example, race in the NHSA PEI categories is different than the CSI categories, is different than the substance use side of the house. So none of it matches, and so we're all having to report out kind of separately. So that's part one of my question. How are you guys handling that? And then I have another really humdinger for you.
Steve, I didn't hear that one.
Basically, different systems are requiring data to be captured differently. And so that it winds up an administrative burden because you have to report it differently in all the 3 different systems.
Right, so that's why I'm really excited about what's happening with the Cradle to Career data system requirement, because that is not about introducing new measures, but really about having a better understanding of connecting data across sectors. And I do think that we as stakeholders should pay a little bit more attention to what's happening over there, because you're absolutely right. If we're all reporting on it differently, there might be some missed opportunities if we actually want to know the same things, but we're using different language.
Yeah, so for like example, privately insured entities and even our like partnership health plan, they're not currently collecting current gender identity and sexual orientation, so all that SOG data is missing. Most counties are starting to get in line with that, in part because of MHSA. But you had a metric you talked about earlier around tackling suicides for the LGBT community, and currently coroner's offices are not required to report or collect current gender identity or sexual orientation. So is there any kind of movement to try and like get other systems to be collecting some of this information? Because otherwise you just have one lane and no information from the other parts.
So again, I think I only heard pieces of it, but the question is about whether or not other entities like the coroner's office is being pushed to collect data differently.
They're similar to everybody else. Otherwise, you just have separate lanes.
That's a really good example. That's not one that has come up for us in terms of coroner's office. Maybe it should. I think that the focus has been more on hospitals and hospital systems and how they speak to what's happening at schools, for example, like who's going into the emergency room because of a mental health issue. But there are probably other entities that we haven't thought of that probably need to also go through this process. So I think it's a good point, but I don't have an answer for that. I don't think those conversations are happening at the moment.
You're good? Okay. Go ahead.
Thank you for being here for this. My question is coming from education. And I think I recognize you from the mental health policy work group, correct?
Probably. I don't know if I'm part of that work group, but I might be. So anyway, my point is that I have been in special education all my life. And one of the things that we discovered in the data collections at the Department of Education was that the CalPAD system, which was the data system for all kids, didn't match the data that was collected under CaseMIS, which was the Special Education Management Information System. And so the state has combined those 2 systems so that the data that you get is actually the same data, since it's all now in one system. Instead of, for example, in the old system, you could have kids with disabilities might be suspended 50% of the time, and yet those kids actually weren't reported in the CalPAD system. So now everything's one and the same. So I'm wondering if that's a model you've looked at, because it took work and change to make, and I'm sure they learned some things in the process. So I'm wondering if you've even seen it, or if something like that would be helpful, because it seems like people just mentioned schools. We have a lot of data on kids. Maybe we all need to be in this together. I'll do it this way. So that is not something that has come up. I think that's a really good point. And, you know, if you ever find yourself in some of these other meetings that the state is talking about data collection, that is probably a really good one to bring up as an example, because I do think that maybe some of our policymakers are feeling a bit overwhelmed on exactly how to do this. So examples of the past would be really helpful.
Nice. But you got to, no, not you, Steve, the other one, but you got to speak loud.
I'm just curious what you think personally and professionally about student data privacy and parent advocacy.
Did you hear that?
I did.
Okay. Yeah. I understand the pause.
So the bad thing about being on screen is you could probably see every facial expression that you probably would not be able to see if I was in person. So obviously, I believe student privacy is important. I think everyone's privacy is important. I will say that I am always wondering whether we're talking about privacy or if we're talking about shame around mental health. That's always a question I have. And the reason being, young people that I've met and interacted with are surprisingly open about their mental health and their mental health struggles. They will go on Twitter and tell the whole world everything all the time, consistently. And it has always felt more resistance from parents to share what's happening, not saying all the time. But that's been my experience. I've met young people who said, I'd love to go to therapy, but mom and dad won't let me, for example. So while I think privacy is important, I think we also have to be sure if what we're doing is actually protecting privacy or if what we're doing is hiding behind a cloak of shame.
There was some applause in the room.
Okay.
For that. And actually enthusiastic applause.
Okay.
Good.
So Lishaun, I know you've addressed this in different ways, but just to be clear, I'm going to make you king of the world right now. And I want to know, how are you going to fix this system once and for all with what you know?
So I don't know who asked that question, but if I knew how to fix the system once and for all, I'd be a very rich woman. So I'm not. So, I really do think though that there's an appetite for change at the moment, and we do have to seize on it. There's money being spent on data. And as you know, this is not a very sexy political topic. So if we're spending money on data and data systems and change, this is a really good time to get some things moving before we lose the appetite for it.
I think he wants you to say a little bit more.
That's a good beginning.
Yeah, so, I don't know how to fix it. That is not, for my personal feeling is we probably need to scrap a lot more before we start building it up. What we see right now is just a really disjointed system. I think we need to have MOUs in place so that we can talk to each other across sectors without problem, without really bumping into those privacy issues that were brought up before. But I think you really do have to break down what's currently in place in order to build something that we want. I don't think anyone thinks that our current data system is working in any real way. So that's a hint to me that we probably should scrap it and start all over again. That's a lot of money though, and I don't know if the state has an appetite to spend that kind of money on data systems in that way, especially if we're talking about eliminating or doing away with a lot of the things that we currently collect. But I do think some kind of clean slate is needed for us to even get to where we want to go.
Do you think about what the return on that investment might be if we went through that pain? What would we gain from doing all that?
That's a big question. I think what we would gain is knowledge of what we were doing right and what we were doing wrong. We don't really know anything about how well kids are doing until it's to the point where they're in the hospital or unfortunately they've died by suicide or overdose, right? So the point is for us not to get to that point to understand that there are alarming things happening. So the return on investment is, one, we get children to adulthood, which I think is the goal. We want kids to thrive, to be alive, to live long, healthy lives. I don't think you can put a number on that. That is just the right to life. The other thing is we would be able to better ascertain which programs are working for these long-term outcomes and goals. We would know if that program that we put into the school actually had the intended consequence, as opposed to we put a program in, but because of the data that we collect, it doesn't really align with the goals of the program, so we have no clue.
So if I understand what you're saying, and I agree with that, if we put the data system in correctly, maybe we could be more preventative, less reactive, and prevention's always going to save more money, and that's something we talked about at the beginning of the conference. Good care costs less. And so that's our incentive to try to get this right.
Yes, and my assumption is if you're at the Breaking Barriers conference, you definitely believe in the public health model of prevention is better than cure. So, that is part of the goal, is that we are investing more in PEI, and that's how we want to live our lives. We don't want it for kids to be at the point where they're in crisis before we reach out.
Yes, I agree. Thank you.
You wore them down. You did good.
I'll have to get a name of who that is.
Steve Carnevale.
I'll tell you later.
I know the voice now. Yes, hi,
Got
Steve.
it. So he let you off gently, as you understand that too, right?
Yes.
That's because you went to Michigan also.
Oh, we're
Yes.
not going there, I promise.
Go blue.
Go blue.
Other questions? Well, then Lishaun, anything, some closing thoughts and what you see is happening next and how you want all of us to be, what you would like us to be doing next?
Well, the good news is everyone seems really engaged on this conversation. I will admit, when we first started this project, we thought it would be a snooze fest. We thought no one would be interested in talking about data, systems, and outcomes and quality metrics. But it's been just the opposite. So one, I'm just really happy and grateful and thankful that everyone is so engaged on this. My only ask or request is that you keep bringing up the importance of good data to the state when you talk to policymakers and when you talk to those in charge, because it's something that they need to hear. And it's not, like I said, it's not the politically sexy thing that our legislators can invest in, but it is what's needed at this time.
I would agree. We can't have data-driven decision-making if we don't have good data. So thank you, Lishaun.
Thank you so much, everyone, and good luck with the rest of the conference.